Hi, everyone, and thank you for joining this applied case. My name is Corey Morrow. I'm an assistant professor of occupational therapy at the Medical University of South Carolina. Today, I'll be presenting a case that exemplifies how we can leverage large data systems to influence health policy, specifically Medicare reimbursement. And we're looking specifically today at power wheelchair seat elevators. Before we begin, please note the following relevant disclosures. So we have several team members, including Dr. Schmeller and myself, who are supported through partnerships, corporate research agreements, or NIH-funded networks. This case is part of the Applied Learning Case Series and is designed to show how system science can inform rehabilitation policy. We'll touch on the financing, organization, and delivery of rehab services and how those components interrelate to shape real-world outcomes, again, specific to reimbursement policy for wheelchairs and seat elevators. A little bit about my background. I'm trained as an occupational therapist, and I'm a health services researcher with a specialty in health economics. And so my passion lies in enhancing access to rehabilitation services and associated technologies, particularly for individuals who rely on mobility devices. Um, I was selected as a Learning Health System Scholar in 2022. I was partnered with the Center for Assistive Technology at the University of Pittsburgh. This is a nationally recognized leader in the provision of mobility devices, and their mission is to improve wheelchair prescription practices and reimbursement policy to better align with the real world needs of individuals living with mobility impairments. So, our interdisciplinary team of clinicians, engineers, data scientists all play a pivotal role in identifying a critical policy gap with Medicare reimbursement and then building the infrastructure to generate data to address this policy gap that we will discuss. So, a little bit about the background of the problem. We're facing a demographic shift, an aging population, and rising rates of disability. There are millions of Americans who rely on mobility devices, and yet falls remain one of the leading causes of injury, hospitalization, and long-term care costs. Despite this, access to assistive technology, such as powered wheelchairs, remains limited. And this is largely due to outdated and cost containment restrictive reimbursement policies that really prohibit our persons with disabilities from getting the types of equipment that will most benefit them. And similar to this, the complex rehabilitation technology, or what I might refer to as CRT, refers to customized mobility devices designed for individuals with significant mobility impairments. These are not one size fits all tools. They're medically necessary. They're highly individualized devices that enable people to engage in daily life with safety and independence. However, as I mentioned before, due to a history of misuse and billing fraud in the wheelchair industry, CMS, the Centers for Medicare and Medicaid Services, implemented strict controls on CRT provision. While the intent was to prevent waste, the result has been a highly restrictive and often dysfunctional system, especially when it comes to accessories like seat elevators. A little more on the prescription policy issues. So here's kind of where the system breaks down. Prescription policies remain diagnosis driven rather than function based. It's not that we lack experts, it's that we have incredibly skilled therapists and assistive technology professionals and clinicians across the country. The part of the problem is that people aren't getting in front of these experts, and even if they do, the equipment is, it exists and it's exceptional, but access is bottlenecked by rigid coverage policies. So even when a patient clearly needs a device to transfer safely or cook independently, if their chart doesn't include the right diagnosis, their claim is likely to be denied. And that's not really a clinical decision, it's a reimbursement problem. So this creates unsafe environments for patients and perpetuates deep inequities in who gets access to this life-changing technology. We aren't going to solve these problems by just opinions alone. And so we needed structured evidence, we need large data sets, nationwide cohorts, and longitudinal studies. And this is where system science comes in. So changing policy requires more than personal stories. It requires data that policymakers can't really ignore, and that data must reflect real world use, real world outcomes, and real world barriers. So that's why multiple stakeholders are essential in this work. We have clinicians, researchers, engineers, assistive technology professionals, patients, and policy writers. I'm an OT and a researcher, but I'm not an ATP. I'm not an engineer. I'm not a Medicare contractor. So what I can do and what our team can do is bring data to the table and then collaborate with the people who hold those other pieces. And that's how change happens when we connect the dots and speak a language that all stakeholders can understand. So getting a little more specific to this case study, we'll be focused on power wheelchair seat elevators. So seat elevators allow users to raise and lower their wheelchair seats. And this improves reach, enhances independence during transfers, and reduces the risk of falls. However, for a long time, Medicare deemed them as not medically necessary and did not cover them due to a perceived lack of evidence. So to address the lack of structured outcomes in the CRT space and with seat elevators in particular, the Center for Assistive Technology at the University of Pittsburgh launched the Functional Mobility Assessment as part of a corporate research agreement. And this registry reflects nationwide patient-reported outcomes focused on satisfaction, function, and real-world device use over time. It's essential to note this type of work isn't possible without true partnership. So the FMA UDS wouldn't exist without collaboration between researchers and industry leaders. On the one hand, you need academic rigor, encompassing statistical methods and clinical interpretations in a robust research environment. However, you also need boots on the ground. You need manufacturers, suppliers, and rehabilitation providers who gather data from patients in real-time, real-world clinics. And so this partnership has created one of the most comprehensive mobility outcomes registries in the country, positioning us to answer questions that Medicare and other payers are demanding before they'll consider policy reform. So today, the data set includes outcomes from over 16,000 users with ongoing enrollment. This provides a scale that enables meaningful statistical analyses, longitudinal tracking, and subgroup comparisons previously that were impossible in this field. And the ultimate goal is to scientifically evaluate which types of wheeled mobility seating devices are most effective for specific patient populations under various circumstances. And that's critical if we're serious about promoting not just safety, but the health, participation, and long-term quality of life for individuals with mobility impairments. So again, coming back to the seat elevator, we leverage multiple data sources. So what's unique is this integration of multiple data sources. So there's the large scale outcomes data from the FMA. We have the biomechanics studies through literature reviews, and we have qualitative comments from over 3,000 different public stakeholders. And this provided us with a comprehensive understanding of how seat elevators affect real world mobility and safety. Our FMA UDS analyses revealed a clear signal, and that's that users of seat elevators report significantly higher satisfaction with mobility, particularly in terms of functional reach and transfers. And this is an outcome that we can anecdotally know or observe in the clinic. However, that outcome is compelling and gets the attention of policymakers when it's backed by large scale data and again, not just anecdotal reports. So this culminated in a 2022 publication by our team, and which provided much needed empirical evidence. Combined with the biomechanical and qualitative data, it laid the groundwork for reconsidering CMS policy. So some legislation updates. In May of 2023, CMS updated its national coverage determination. So seat elevators are now considered medically necessary when specific functional criteria are met. This policy reversal was a direct result of our team's data-driven advocacy, alongside the public testimonial of those 3,000 qualitative comments, and of course, coalition efforts and teamwork. So this is a very significant victory for wheelchair users, clinicians, and the broader rehab community. Some of our other more recent work, we have a couple of publications using the FMA UDS, exploring the prevalence of falls for different types of mobility device users, and an exploratory analysis describing mobility device evaluations delivered via telehealth. The FMA UDS registry opens doors for many future studies as well. So this project has already sparked multiple new initiatives, including a Medicare cost analysis of customized power wheelchairs. So we're now exploring the cost effectiveness of custom versus non-custom devices. We're looking at long-term outcomes like falls, skin health, pressure injuries, and overall mobility-related satisfaction. And we're looking at intervention models to reduce downstream costs. So some just final thoughts here. The big takeaway, it's not enough to say this device or this accessory helps my patient. If we want true change, if we want to really influence our reimbursement policy, we need scalable, structured data that policymakers can act on. And by combining registry data with coalition advocacy and consumer voices, we can reshape the systems that serve our most vulnerable populations. Just a big thank you to my collaborators, the Center for Assistive Technology at the University of Pittsburgh, and the whole LeaRRn network. This work reflects the power of interdisciplinary system level thinking and a shared commitment to making rehab care more accessible and evidence-based. Thank you for your time. If you'd like to learn more or collaborate, please do not hesitate to reach out to me. I'd be happy to answer any more questions and continue with our work here. Thanks.